Good morning, everyone. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Today, I wanted to discuss with you history taking in gynecology. I want to discuss today opening the consultation, personal history, complaint of the patient, menstrual history, obstetric history, past history, family history, sexual history, and the present history. Let's start. First, introduce yourself, including your name, your position, and the role. Explain the need to take history and gain consent from the patient. Respect confidentiality and the dignity. You should have skills to manage sensitive topics, also to especially challenge with silent patient, talkative, angry, and depressed patient. Chaperone could be present, like her sister, her husband, or her mom. What about the personal history? We need to know the name of the patient, which is important, to call her by her name, to register her name in the file, and be familiar with the patient. Age is very important because certain problems commoner in certain age, like in abnormal uterine bleeding, complication of pregnancy, or uterine fibroid in childbearing age is the commonest causes, while in postmenopausal age, abnormal uterine bleeding is due to atrophic endometritis or endometrial hyperplasia or endometrial carcinoma. Occupation is also important to know the social factor and the financial state of the patient, and also because certain occupation expose the patient to risk factors, like workers may be prolonged standing and hard working may lead to prolapse of genital prolapse, for example. Residence is also important. If she is nearby to hospital, if she will be tolerant and do screening program. So residence also is important. I give you also an idea about the social factor and the financial state. Duration of marriage is important for cases with infertility and the number of living children. Special habits like smoking, like alcohol drinking is very important. Also drug abuse. Complaint of the patient should be in patient own words. So what's brought you in today? You should ask the patient. The complaint may be pain, bleeding, discharge, vaginal discharge, swelling, inability to conceive, and as we mentioned, in patient own words. If you have more than 2 complaints, so arrange chronologically. What about the menstrual history? Menarche, which is the first day of the first menstruation in woman's life. Of course, the age of 12 years old on average is the age of menarche. Cycle rhythm may be regular or irregular. Regular if variation of menstrual cycle length measured over 12 months less than 20 days. Irregular if more than 20 days. The cycle length is the duration from the first day of the cycle to the first day of the next cycle. Normal cycle length simply 28 plus or minus 7 days. And this is all the definition. But recently, FIGO published in 2011 an article with new definitions to the menstrual cycle, mentioned that the range of the length of the cycle from 24 to 38 days. The duration of menstrual flow is from 2 to 8 days, but as regard FIGO 2011, it lasts 4 to 8 days. Character of the flow, like amount, color, and odor, should be mentioned. How to know heaviness of the menstrual bleeding? By the number of tampons per day, by the presence of clots, by flooding, need for double protection, and bright red color in menstruation. Dysmenorrhea, which is painful menstruation that affected the daily activity of the lady, should be mentioned if positive or negative. The intermenstrual period, is it free from pain, bleeding, or discharge or not? The use of contraception, if currently, what is the type of contraception used and the duration of its use? The last normal menstrual period should be registered. And if the patient is menopause, I should register the age of menopause and the duration of postmenopausal period. As regard the article published by the FIGO in 2011, a normal menstrual cycle defined as it is a menstrual cycle that has a frequency of 24 to 38 days, lasts 4 to 8 days, with 5 to 80 milliliter of blood loss, and the variation of the menstrual cycle length measured over 12 months less than 20 days. And as you see in this picture, this is the menstrual cycle, this is the menstrual phase, and this is the proliferative phase, and this is the secretory phase, and this is the next menstrual phase. Also, this is the follicular phase, and this is the luteal phase, and this is the LH surge. Some important definitions you should know about abnormal uterine bleeding, which is a broad term that describes irregularities in the menstrual cycle involving frequency, regularity, duration, and volume of the flow. Intermenstrual bleeding is the bleeding that occurs between otherwise normal menstrual periods. Abnormal bleeding is considered chronic or acute. Chronic when it has occurred for most of the previous 6 months, or acute when an episode of heavy bleeding warrants immediate intervention. Some definitions, medical terms used in the past, like menorrhagia, which is excessive and or prolonged menstruation, metrorrhagia, irregular or cyclic bleeding, intermittent or continuous, menometrorrhagia, irregular or cyclic bleeding and of excessive amount, menostaxis, regular period but prolonged duration, polymenorrhea, frequent menstruation at regular interval, polymenorrhagia, frequent heavy period, intermenstrual bleeding, uterine bleeding of variable amounts occurring between regular menstrual periods, breakthrough bleeding, spotting or mild bleeding during the intermenstrual period during hormonal therapy. Hypomenorrhea means scanty menstruation. Oligomenorrhea means infrequent menstruation. What about the obstetric history? What are the items? Gravidity, parity, deliveries, miscarriage, previous pregnancies, previous puerperia. Let us start with the gravidity, which is the number of times a woman has been pregnant regardless of the outcome and whether normal or abnormal. Parity is number of deliveries after completed 28 gestational age weeks, whether normal or abnormal. This is in Egypt. You should know that the medical legal viability is 20 weeks in USA, 24 weeks in UK, and 28 weeks in Egypt. Again, in obstetric history, deliveries. We should know full-term normal deliveries, how many, and how many abnormal deliveries, and what are the characters of each one, and date of last delivery. Let us know the definition of full-term normal delivery: single spontaneous delivery of a viable fetus, mature, presented by vertex through the natural birth canal within reasonable time, without maternal or fetal complication, and without aid. Reasonable time means between 3 to 24 hours. What about the abnormal deliveries? Abnormal deliveries may be instrumental deliveries, like in this picture, forceps and ventouse, or multiple pregnancy, like this picture, twins, or preterm birth, or malpresentation, like this picture, breech presentation, or dead fetus, what's called stillbirth, or cesarean section, or prolonged labor more than 24 hours, or precipitate labor less than 3 hours, or maternal or fetal complications, or preterm birth, or post-term birth. All these are considered abnormal deliveries and should be registered. Miscarriage, we wanted to know the number of miscarriage or abortions, sequential or not, the gestational age in each pregnancy ended by miscarriage, the onset, is it spontaneous or induced, and the method of termination, is it spontaneous or medical or surgical termination, and the date of last abortion should be registered. What about the previous pregnancies? Was it normal or abnormal? If abnormal, what is the complication? Maybe preeclampsia, maybe gestational diabetes, maybe premature rupture of membrane or chorioamnionitis. All of these findings should be registered. What about the previous period? Was it normal or not? What is the abnormality in previous period? Maybe postpartum hemorrhage or deep venous thrombosis or berber sepsis. Let us present the obstetric history in the form of gravidity, parity, and abortion. G for gravidity, B for parity, A for abortion. So G2, B1, A1 means 2 pregnancies, 1 parity, 1 delivery, and 1 abortion. There is another method to present the obstetric history called 5-system method, which include G for gravidity, T for term birth, B for premature birth, A for abortions, L for living children. So G4, T1, B1, A2, L2 presented as 4 pregnancies, 1 term birth, 1 premature birth, 2 abortions, and 2 living children. Let us go to the past history, what we wanted to know, the medical disorders or drug and allergy history. Any past history of PID, pelvic inflammatory disease, past history of gynecologic therapy like hormonal therapy in cases of abnormal uterine bleeding, past history of contraception and which method was used and the duration of its use, surgical operations, whatever general surgery like cholecystectomy, appendectomy, or gynecologic surgery like D&C, myomectomy, repair of prolapse. Smear history is something very important to know and register the date and the result of last cervical smear, especially in cervical screening program. What about the family history? Familial disease, whatever hereditary or non-hereditary, is something very important. Hereditary, for example, like diabetes and hypertension, and what is very important really, the family cancer syndrome, hereditary breast ovarian cancer syndrome, and hereditary non-polyposis colon cancer like Lynch syndrome. Or non-hereditary disease like TB, tuberculosis, or rheumatic heart disease, ask in family history also about any similar condition in the family. What about the sexual history? Some patients may not be comfortable talking about their sexual history, sex partner, or sexual practices. Please try to put patient at ease and let them know that taking a sexual history is an important part of a regular physical history. Dialogue with patient. I'm going to ask you a few questions about your sexual health and sexual practices. I understand these questions are very personal, but they are important for your overall health. The information is kept in strict confidence. Do you have any questions before we get started? So please do the dialogue like that. Okay, what we wanted to ask in sexual history, we wanted to ask about the frequency of coitus, and it should be registered per week, twice per week, 3 times per week, and so on. Of course, it is different between people and according to the age of the couple, and also according to the occupation and the type of the occupation, stressful or not, and so on. Position during coitus, the commonest position is the dorsal position, another position like knee chest position, especially in cases with RVF. Uterus, presence of libido, it is the female sexual desire. It is mentioned as positive or negative. Lack of libido is called frigidity. Then ask about the presence of orgasm, which is the climax of sexual pleasure. Ask about dyspareunia, if positive or negative, which is pain during intercourse, and it may be superficial or deep. Aparonia due to vaginismus, which is failure of intermission. Use of lubricant during intercourse to facilitate intermission should be mentioned because some lubricants may be spermicidal. Flower semenis, it means escape of semen from vagina immediately after ejaculation, and to some extent it is something physiological and can happen. Postcoital vaginal douche should be mentioned because some vaginal douches are spermicidal also, and you should inform the patient about that. Use of any protection against sexually transmitted disease like barrier, like condom, and if any past history of sexual transmitted disease for the patient herself or her partner should be mentioned. Again, in sexual history, by the end of the discussion of this item, the patient may have come up with information or questions that she wasn't ready to discuss earlier. So ask her, what other concern or question regarding your sexual health or sexual practices would you like to discuss? This is very important. I wanted to focus in this slide about sexually acquired condition which may cause morbidity. HIV infection, which cause immune suppression. Hepatitis B infection, which cause chronic hepatitis and later on in life hepatoma. Hepatitis C infection, which cause liver cirrhosis and hepatocellular cancer. Sperm itself may cause unwanted pregnancy, which may cause the lady to try termination of this pregnancy, illegal termination under a septic condition, which may cause sepsis and septicemia. Oncogenic human papillomavirus cause cervical infection, cervical intraepithelial neoplasia, and may lead to, later on in life, cervical cancer. Chlamydia trachomatis cause pelvic inflammatory disease and fallopian tube pathology, which may cause ectopic pregnancy or infertility because of tubal pathology. Treponema pallidum latency may lead to, later on in life, to tertiary syphilis. What about present history? Analysis of the complaint as regard onset, course, duration, severity, precipitating and relieving factors. Any complaint like pain, bleeding, discharge, whatever, swelling. Other symptoms related to main complaint should be analyzed. Also, I need to know the investigation done and the drug therapy in the current condition. Symptoms also suggesting urinary or GIT or other body system problems. For example, for discharge, what we wanna to ask about: the color, the amount, the smell, is it offensive or not, associated with itching, the duration of this discharge, timing within menstrual cycle, associated with rash or not, any symptom in a partner. As regard if the complaint is pain, what we wanted to ask about: duration, type, alleviating or aggravating factors, radiation, is this pain radiating like suprapubic pain radiating to the back, in relation to menstrual cycle, mid-cycle or period related, any possibility of pregnancy, you should consider ectopic, bowel problems, any feeling of something coming down below and heaviness, because it may be a prolapse, genital prolapse, presence of dyspareunia, which is painful intercourse. Then, closing the consultation, summarize the history and ask the patient if there is anything else she would like to add, and then thank the patient for her cooperation. Lastly, I wanna to focus in this slide about the diagnosis. Diagnosis includes 3 items: history, examination, investigation. So to reach a diagnosis, I should take a very good history, I do a very well examination, then the proper investigation to reach the diagnosis. And the diagnosis is composed of etiological item, anatomical item, and the functional one. For example, post-menopause cystorectocele and second-degree uterine descent and stress incontinence. Etiological is post-menopause because of weakness of the ligaments. Anatomical, cystorectocele and second-degree uterine descent. Functional is stress incontinence. So, This is the complete diagnosis, include etiological, anatomical, and the functional parts. Of course, to reach this diagnosis, I should fulfill the history, the examination, investigation. And today in our lecture, we only finished the history in gynecologic case. So, to summarize our lecture, we have a journey today through the personal history, complaint of the patient, menstrual history, obstetric history, past history, family history, sexual history, and present history. And this is the end of my lecture. Thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.